Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 16. Dang, 16 already of the Movement Debrief. And today we're going to talk about three things. Unless I'm feeling frisky, then maybe we'll talk about more. Who knows? What we're going to talk about today will include some of the readiness measures that I used in the NBA D-League. We're going to talk about how to navigate those pesky flare-ups when those bad boys happen, when your patients and your peeps, and maybe even you, are having a rough day. And we're going to talk about the OCS or just clinical specialties in general, and are those worth getting? But first, a little bit of housekeeping. Did you guys see my blog this past week? So this one, I linked to a guest post that I did on my boy, Mike Robertson's website, robertsontrainingsystems.com. We talked about practical basketball conditioning and how I prescribed basketball conditioning for my peeps and how I would do that now. And even with a couple of the basketball players that I've worked with in clinic, how I've used those exact same strategies I used with pro athletes. So that was there first. That was what we got for housekeeping in terms of the blog. Other things going on in life. Oh, I got a couple speaking engagements coming up. So if you are by chance in the land of China, I think it's October 27th, 28th, I got two talks that I'm going to be doing, which I'm pretty darn excited about. One's going to be on pine, the other's going to be on respiration. So stay tuned for that. But the bigger one, in case you're not going to be in the land of China, is going to be in September. Don't have all the details ironed out yet, and not this September, but September of next year. So mark it on your calendars. I think it's the 17th, 18th, somewhere around that weekend. But I am going to be presenting a 2-day seminar in Seattle, Washington. So stay tuned on that. I'll give you guys more details once I have more details ironed out on it. But it's going to be at my boy Michael Lee's place. He's a chiro out of Seattle. Awesome dude. And it should be a lot of fun. I think that's all I got housekeeping-wise. Except I was in Vegas this past weekend. If anyone's hiring a PT out in Vegas, hit me up because that place is awesome. Man, I had a great time out there. It's kind of cool being there for the fight. Now, I wasn't at the fight, but just in the area for the fight. A lot of fun. And I won some money in poker, so that's always cool. And it's kind of like, it made me realize how much I miss big cities. Just being around a lot of people, that just provides a different energy. And I feel like on the Strip, you kind of get like a super big city feel, but you could go out and you could hike and stuff like that, which kind of the best of both worlds for me. So I may need to move out to Vegas or something, man. That place was just a blast and a half. So that's it for housekeeping. Let's dive into today's debrief. So question number one, a couple of these are Q&A, a couple of these are just me reflecting on life and such. First question comes from my man Gerard. He hit me up earlier today and he asked, "Hey Zach, what measures did you all look at when you were in the NBA D-League to help your peeps?" Great question, Gerard. And so there were a few different measures that we looked at. First, let's talk about pre-event measures. And so that would be questions that I would ask my peeps before a practice or before a game. And those included how many hours you slept, number one. How would you rate the quality on a 1 to 10 scale? All these were 1 to 10, except sleep. I mean, you could theoretically sleep more than that, but I mean, if you're hitting 10 plus, I think you're okay. So hours slept, quality, soreness rating 1 to 10, 1 being not sore, 10 being sore as all hell. Then we have stress on a 1 to 10 scale, and then the last one was readiness for the activities at hand. And so if you had a light practice, how ready were you for that on a 1 to 10 scale? And basically, with those measures, what I did was I collected them with all the people, and depending on what they said, that led to us having conversations regarding a multitude of factors. It's like, if they're not sleeping well, okay, well, then maybe we can intervene on some of these measures and say, well, okay, why aren't you sleeping well? And maybe it's something with their environment, or maybe because it's the NBA D League and no one's sleeping well. Or maybe they're on their phones really late, or maybe they're doing inappropriate things that are keeping them up at night. And then maybe with quality, it's, one thing that I've been doing with a lot of people lately is if I have someone who wakes up in the middle of the night, as an example, and this was common in the D League as well, as, they'd be sleeping like, man, I just, at 2 a.m. it seems like I'm pretty consistently wake up. Check your temperature of your room. If you got a hot room, as your body sinks into REM sleep, and what happens when you're in REM cycles is you don't have as adequate temperature regulation. You rely more on the environment, namely the air that you breathe, because that's how we dictate body temperature in that case. That's why even if you have a super cold room but you're snuggled up, you're still getting that sensory input saying that it's cold through respiration. And so if you have a hot room and your body, or the air that you breathe, is much warmer, that's going to rise up your body temperature. And so what that can either do is that can wake you up, one, or two, it can give you really bad nightmares. Neither are very cool things you want. And so what do? Well, decrease the temperature. Have it below, at the minimum, below 70, but I tell most people between 60 and 68. And I've had a couple people in the D League where we just made that tweak and that made all the difference. I have a patient I'm working with right now where that was the difference maker. It's like she was getting just a couple hours of sleep at a given time, and it was very broken up, and we did that, and now she's getting straight 8s. So just side note, but that was the sleep measures. And then if we had someone who was stressed, well, we figured out why that was, and see if there was anything that we could do to intervene in that regard. Soreness, obviously that can dictate potential manual therapy interventions, or we drive them to possible recovery modalities. And then readiness, that helped us create a conversation and ammo to say, hey, do we need to make adjustments to the practice plan? And then after the session for the day, I asked them rating of perceived exertion, which was again on 1 to 10 scale, and we used those measures to make decisions. So that was really what we looked at from the D League standpoint. And all of these measures can be done without any cost. It's just about having a conversation with your peeps. And so things that would have changed, and let's say that you're not, you can't add any sports science measures like Catapult or Stat Sports or some of the RFID stuff that people are using now. What would I have done differently? And let's say that those aren't allowed. Couple things, because I definitely didn't do this perfect. I probably would have condensed the questionnaire a bit further. And I think the 3 things I would have kept would have been hours slept, sleep quality, and then how ready are you for today? Or maybe a question like, overall, hey, how you doing today? Because I think that last question can encapsulate the other 3. And even though we could potentially intervene on the latter 3, it's much harder to do so than maybe something like sleep. But what I think it does is when you ask too many readiness questions, it eliminates the conversation piece. And I think that's, well, that you can't objectively measure that and you can't intervene. There's something to rapport building and building relationships and having that conversation to where you can get a feel for how your guys doing, and is this a good day to train, or is it a good day to back off, or is it a good day to do something else, or do we need to alter the game plan for you? And I don't think I think when you eliminate that conversation, it can leave a bunch of holes. And maybe if they are stressed, being able to just come to that organically in a conversation that's maybe sparked by this questionnaire, maybe you can get more information about what those stressors are, and that can lead to other conversations in terms of how can what steps can we take to maybe mitigate that stressor. So from a daily subjective questionnaire, I would have condensed even further. And I think too, even though I had really good compliance, we would have gotten even more compliance had we done that. And so that's what I would have changed with the readiness questionnaires. With the rating of perceived exertion, the one error I made was, well, so what I did with that was I monitored their acute to chronic workload ratio, and I only did internal measures. So for that, what I did was session duration times rating of perceived exertion, and that spit out a number, and then we could measure acute to chronic workload ratio based on that. What I would have done differently, two things. One, I would have used the session duration at basketball only, because one error that I made is that these ratios are only activity specific. So I can't progress workload if I'm using numbers such as maybe a separate conditioning session that's non-weight bearing plus a weight training session to translate to playing on the basketball court. It just doesn't work that way. General physical preparation does not equal specific physical preparation. I would have been better served had I just used basketball data. I would have also been better served had I used an external load measure, because the more flags we can potentially have, and part of the daily readiness stuff is one of those flags, the more credence we have to make decisions. And so what kind of external load stuff could I have done possibly without equipment like Catapult or Stat Sports, because that's where that stuff really excels, and I wish I had used that stuff in hindsight. I think what I would have done is I still would have taken in session duration, but maybe I would have counted the number of drill repetitions, or yeah, that probably actually would have been the best thing I would have done, and then maybe given some type of rating based on intensity with each of those drill measures, or time, or been more specific, like, okay, this drill took X amount of time multiplied by how many repetitions, and then that gives us a number, and then we just add all of that up totally, and that is what allows us to measure external load effectively. It would have been a lot more work, and you would have had to do a lot more paying attention in practice, not just to how guys are moving, but also like counting drills. But it would have given me more sports science measures to make better informed decisions. Then again, too, though, now that I think about it, I think there was a tremendous value in just watching the guys move, right? While that's not an objective measure that you can't necessarily intervene on, it tells you a lot about how guys are doing, especially if you got someone who's, rates all their readiness measures as 10 all the time, and then you watch them practice and they look like absolute trash. I mean, what is the point of these measures then? It's like you kind of have to have a delicate balance of all these factors, and I think that's where it helps to have multiple data points, but also multiple people paying attention to what's going on with their various strengths and skill sets. And so maybe I would have had the ATC that I worked with, time the drills and count how many drills were performed, and that's a way we could look at external load. There's probably multiple ways to skin that proverbial cat. As long as the cat gets skinned, that's the important thing. So that's basically all that I got for the D-League stuff. Next question, navigating flare-ups. Let me get a sip of water. You guys like how I'm classing up with the glasses and the tank, by the way? I did some tempo runs earlier before this, so I kind of wanted to chill, but I also wanted to keep my eyes relaxed. Anyways, navigating flare-ups. So I had a patient today, and this woman's been dealing with some back pain. She hurt herself at work. Sweet lady, and you know, we do things at PT, and she gets to feeling great. You know, I'm doing awesome. Look, I'm actually walking. Blah 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 blah. And then what does she do? Well, she goes way beyond her means and does a crap ton of activity, and then boom, get a flare up, in pain, back to square one. And that happened today. And so she called me and she said, "Hey Zach, so I hurt my back again. This time it was something else. You know, I went and bent forward, and all of a sudden my back seized up. Should I come in?" And first off, thank the Lord, thank the Maker she called me. Because I feel like, I'm sure we've all run into this, but there's some people who say, "Hey, I hurt too bad to come into PT." It's like, fam, why do you think you're coming to see me? That's when I want to see you, because maybe we can do something to help you navigate this. But fortunately she called, and I said, yes, you know, if you feel as though you can come in and it's not going to flare you up even further, right? Because what I don't want to do is the physical act of getting into the car, driving to the clinic, getting out of the car and walking is setting her off to an even worse standpoint. Like, if that was the thing that would have had her way go off the edge, then it's not something I would have done. And I would have said no. But since she felt that she could have comfortably done that, we went and proceeded. And so when you have someone who's flared up, how do you navigate this? And how do you coach them to navigate this situation? As you guys know from a prior blog, and I'll link that in the show notes, there's 4 areas from a physical activity standpoint that I like to intervene on with people. The first is knowledge. And so with this woman, we have to talk about what a flare-up is, what does it mean, and what type of activity person she is, okay? So first, what is a flare-up? Well, flare-up is when your activity levels go past a point of no return, and that leads to a large increase in pain and possibly an inflammatory response. And that can be either non-neurogenic inflammation, where maybe there is a little bit of a tissue injury, or neurogenic inflammation, where the nervous system just upregulates its sensitivity and leads to a lot of lovely inflammatory soup chemicals kicking into the area. And so we talked about, okay, what a flare-up means. And I think the important thing we have to understand is that when you do have a flare-up, it doesn't necessarily mean that you re-injured the tissue. Because tissue tolerance, let me draw this up. Okay, so let's say we have a mountain, and as you go up the mountain, right there, as you go up the mountain, that's an increase in physical activity. At some point in time, this line right here, you're going to injure a tissue, okay? We don't want to get there. Typically, after an injury, after you injure yourself, the line at which pain is produced is significantly lower. Like pre-injury, it might be somewhere around here, but post-injury, it drops, okay? So first off, we have to educate our peeps and say, guess what? That means you got a little bit of a buffer before you get into some serious shiznit, right? So pain's here. But in this case, this is what we have to make my woman aware of, or people who have flare-ups. Is somewhere before tissue injury, but somewhere after pain, we have the big FU line, and that's the flare-up line, right? That's where these events start to happen, okay? So what we have to understand is when we are managing or navigating flare-ups is sometimes we're going to go over this. Don't freak out, because you probably didn't injure yourself. But we also have to realize that there's only a certain amount of activity we can do beyond our means before we get here, right? And this is a woman who does the classic boom-bust kind of thing. And what that is we have a woman who, when she's feeling great, she goes way beyond her conditioning means or her capacity. That leads to an increase in pain. Then she has to chill, and then so on and so forth, and the cycle repeats. Eventually, the pain system in our bodies, what that will do is it will further decrease the amount of activity needed for pain to be produced. One, as a protective measure, two, but also because of decreased conditioning levels. Right? We don't want this to happen. The opposite of that would be someone who, I'm not going to even touch pain, right? Someone who has fear avoidance, where they never approach the threshold of pain. And so what happens? Well, the threshold becomes lowered for the exact same reasons. So you get a lowering of the pain threshold because of protective measures and decreased conditioning levels in both of those cases. In this case, obviously, when you're dealing with a flare-up, that's typically because you have someone who goes beyond their capacity, right? So we make this person aware that they likely didn't hurt themselves, but that is the pain system's normal protective measures kicking into high gear to make sure you don't make the same mistake twice, which is sustain an injury. So first off, making them aware of that. So that's the knowledge piece. Second is still trying to improve variability. So we have knowledge. Once knowledge is established, then we can go on to improve variability, which is giving someone the ability to move, or multiple options to move, or the capability of moving in 3 planes. And so with her, she was still able to do the activities that I had given her previously, so we kept on with those. And one thing too with this, and this is probably a point that I missed over in the knowledge piece, is we have to make sure to educate our patients that when you have a flare-up, the worst thing you can do is nothing. And that's true of any pain syndrome or any time you're experiencing pain, because you're going to lose conditioning, one, and we know that movement is generally a helpful thing to do when you're in pain, because it increases conditioning levels, it produces a lot of the happy chemicals, the endorphins, the enkephalin, serotonin, what have you, that reduce pain. It helps mobilize inflammatory chemicals outside of the area that's hurt. A lot of good things. And so it seems like anytime someone gets a flare-up that I've worked with, and this is probably because I've poorly educated them, that they just stop doing things or they don't do their exercises. And that's one of the first questions I'll ask is like, did you do your stuff? I said, well, no, I hurt. That's what it's there for, right? So what I educated her to do was, hey, let's just go over these, make sure that those are okay. She was able to do them both without pain. I said, okay, cool. So if this happens again, you know you have activities that you can do that will help you feel better. And she did feel better after she did them. So that's step 2. Improve variability. That's what those activities were for. And make sure that your peeps are doing them when they have these flare-ups. Right? Now let's say that these activities made her feel worse. Well, then you have to find another option. And maybe what I typically do with my peeps is I give them all these activities, or I keep continuing to progress them to more and more complex things. And if, let's say, the ones you're doing right now hurt, drop down the hierarchy. Okay? Because we know that those are less challenging, less complex, and they've helped you previously. And so that's what I would have done in this case. Or maybe we give her a new option that still works on the things that she's currently doing. So that's all of the variability piece. The other 2 components that I address are power and capacity. And so with these, I kind of combine them. With my woman in particular, she is walking with a walker because of her her back trouble right now. And so what we're doing is, when she had this most recent flare-up, she went and bent forward into something and tried to pick something up, right? So I educated her on, hey, look, you're still standing with support. So maybe doing something without support that is potentially threatening or problematic with your back might not be the best option for you. So we want to make sure that they're doing movements that are within their power and capacity capabilities. And so this wasn't me telling her to avoid picking things up off the ground. Instead, I gave her a different solution. I said, hey, you know, when you sit and you bend forward, it doesn't seem to hurt. So why don't, if you have to pick something up off the ground, why don't you go after that? Or pick something up in that fashion? And she said, okay, I can do that. That way we're still making sure that she's moving, but we're doing it in a position that she knows that she's safe in, and we know that she's safe in. Okay? The other thing to increase capacity is we want to make sure that she's moving as much as she possibly can within a pain-free range. And so, right trunk rotation hurt her. So what I ever do, I said, hey, make sure you're still doing stuff, picking objects up with your arms, make sure you're rotating to the left, make sure you're moving your legs around, make sure you're moving all the areas that don't hurt, and moving as much as you can in a pain-free range. And moreover, remember, we still got a little bit of a buffer before we hit here, so don't be afraid to explore and test those ranges that they may hurt now, but maybe a couple hours from now it might not be as bad, or maybe you can move a little bit farther. Don't be afraid to knock on that door of discomfort. Just don't bust it down like you did last time. And so we want to encourage that she continues to move as much as she can. Another thing to build capacity, because we had her walk around just a little bit in clinic because she was, after we did some activities, able to walk with much less pain, but she fatigues really quickly. And so what did I have her do? Well, I had her walk a little bit until she got tired, and then we sat and rested. And so another education point is, look, as you are moving less, you are building, or you are losing conditioning and fitness levels. So as much as you can, walk around, and we do this in intervals throughout the course of the day until the point that you start to get tired or you start to notice your breath increase, and then just stop and rest. All of these things are encouraging her to continue to move, but do so in a pain-free manner, and do so in ranges that she's comfortable with, while building conditioning and increasing movement variability. And so to summarize that, what do we got to do? We got to educate our peeps to make sure that they understand what flare-ups mean. We have to educate them on what is safe activity and what is maybe activity that they're not ready for yet. We have to educate them on building conditioning, and most importantly, we have to educate them on continuing to do their activities when they're hurting and not be afraid to move when these flare-ups occur. So that's how I generally navigate flare-ups with my people that I'm working with. And again, guys, while you guys are listening to me, please comment if you got some other strategies that you like that are helpful, because it helps the community of people who are talking. Last thing, should you get the OCS? So, I'm an OCS guy. Yep. No, just kidding. I really don't advertise it that much, but I got my OCS when I was I did a residency, my first year out of physical therapy school with St. Ambrose University, and I got my OCS my first year out because that's when I was able to take the test. And so what is the OCS, for those who don't know? Or any clinical specialty for that matter. Basically what it is it's a designation that you are a specialist in orthopedics. And so there's a couple ways you can, in orthopedics as one example, there's sports, there's geriatrics, there's neuro, there's peds, there's cardio palm. I haven't been in the game for a little bit in that regard, so I don't know all of the specialists or specialties that they've come across. So I decided to go the OCS route because it was St. Ambrose and it was pretty simple, and I liked orthopedics at that time, and honestly, Gray Cook had the OCS, and I'm like, you know what, Gray Cook's got the OCS, I'm going to get the OCS. And so I went through residency 1 year, and that gave me enough clinical hours to sit for the exam. If you don't have that, you probably have to get enough clinical hours within your domain that you want to specialize in to be able to sit for the exam. I don't know how many that is now. So I had a guy who was asking me, Tom is his name, and he was asking me, what is there any benefits to getting the OCS? And let's talk a little bit about what's good and maybe what's not so good about going down this route. So let's talk about the pros first. And I can only speak on the OCS's behalf. I think one thing that is immensely beneficial for getting an OCS is it does upgrade your clinical reasoning skills from a biomedical standpoint to a very high degree. So what do I mean by that? When I had to study for this exam, you're exposed to various pathologies. You have to think more from a biomedical standpoint. We had to learn imaging, x-rays, MRIs, CTs. We had to integrate much more with physicians, a lot of these things. And I think that that's important to do, not necessarily from a treatment standpoint, but from a making sure you can help the people that are in front of you standpoint. So like a differential diagnosis among these types of things. It definitely prepares you for those possibilities, because what if you have someone who has cauda equina, right? While this is something we learn in school, I think it's an important thing to reinforce. And in my residency, the art of reflection, sorry, I realize that's glaring, guys. The art of reflection was something that was really emphasized, and reflecting on these cases from that standpoint, and attempting to determine a structure at fault was, while I don't necessarily think that way now, was helpful at the time. And I do think that there is some merit to that thought process, but only insofar as it allows you to determine if this is someone you can help or someone you need to refer out. And I think that's really the biggest crux of the OCS in terms of what I got out of it. Other things that are beneficial, well, I think that the fact that you have a focused period of study on given topics is very helpful. I learned a lot about the anatomy of all the joints, different post-operative protocols, which were really helpful, all of those types of things. We got really focused on specific areas. So I think that was incredibly helpful. And if it sounds like those two areas are holes in your game, then maybe it's something worthwhile to go through. In terms of cons, while I think it makes you a better diagnostician, at least the OCS, I don't necessarily think it makes you a more effective clinician. Probably more so than, say, a grad, but I think one thing that's glossed over with the OCS is the systemic influences of treatment. A lot of it is, this is where you hurt, look at the joint above and below, but don't look at everything. And I think that's much more meaningful when you're treating someone, because the movement system often works in patterns, and a lot of areas can be impacted when someone's in pain, among other things. And that's something that is sorely lacking in the OCS curriculum. Not only that, but it's just lacking in the physical therapy curriculum, period. And I think it's critical and incredibly important to helping someone. You need to learn everything about movement as much as you can. And not only that, but I think from an exercise standpoint, and I can only speak on the OCS, but it's very much more manual therapy based than it is therapeutic exercise based. And I think therapeutic exercise is the thing that's really going to hit home for people. because they can't take me with them unless they pay me a lot of money. But they can take exercise programs with them. And if you aren't thinking globally, you're only going to get so far with your exercise program. So I think that's one negative about the OCS. Another negative, it costs a lot, and especially if you go the residency route. My first year out, I made half salary. Still struggling from that. And it's not something I've ever made up because of the OCS. I got a little bit of a raise my first year out from getting that, but most people don't. So it's definitely not a money maker by any means. Now that said, there are certain positions that having a clinical specialty may get you access to. For example, I know a lot of pro sports teams are looking at hiring clinical specialists. There are certain companies that is kind of a requisite. So in that case, it can be helpful, but it's a costly endeavor in order to do so. Another con is that the patients don't really care. Like I have never in my years that I've been a PT had a referral because I was an OCS, or the patient's been like, oh, he's an OCS, he's got to know his stuff. They don't know any different. And maybe that's just because we as physical therapists are poor marketers. I can't tell you how many times this week, and this was going to be a topic unto itself, but I can't tell you how many times this week that I've had patients where the option was either get a shot or get surgery. And we were never in that conversation, which is devastating. And it's like, you know, we're arguing about kinesio tape on the interwebs, and that's a much bigger problem, people, that we got to address. So you know, from a referral standpoint, though, that's a side note. From a referral standpoint, I don't think the OCS is going to help you in that regard. So in terms of the decision making, I think you have to look at all those factors. You know, are you willing to take a financial hit to get this? Do the costs outweigh the benefits, or vice versa? Do the benefits outweigh the costs? I think if you have some major differential diagnosis holes in your game, it's definitely a good certification to go through, or process to go through. Would I go through a residency to do it? I don't know. Depends on how much money you're going to lose, honestly. And I hate to say that because I know it's not just about the money, but like, that was a sizable hit that I'm still paying for to this day without a big ROI, aside from I can maybe help people a little bit better, or at least stratify people into who I can and can't help. So I don't know if I would do a residency again if I had the option. I think the biggest thing you need coming out of PT school is some type of mentor, you know, and maybe that's a good clinician that you're working with, or maybe that's a mentorship program online like I offer. You need someone to bounce ideas off of, to help you think through things, and to save you time, because if you have someone who's already made all the mistakes and you can just steal, you know, learn from those mistakes, that just expedites your learning process to the nth degree. And so I think as long as you have some mentor, residency is not necessarily required. And, you know, depending on what you want to do professionally, a clinical specialty may or may not be required. You just kind of have to evaluate what financial benefits you're going to get, one, from doing so, or what opportunities that may allow you to have. And you know, if it's worth it, if it's worth that much of a year's worth of study, if not more, to help stratify your patients more effectively. And those are questions that I can't answer for you. So I think that's probably a good stopping point for today. I want to thank everyone for listening in to today's debrief. And it's getting dark too, so I probably should wrap this up right quick. So where can you learn more? I'm glad you asked. So first off, check me out on zachcouples.com. That's my website. Subscribe to my newsletter. You can get a free acute to chronic workload calculator. You can get a free basketball conditioning program. You can get some audio stuff that I've done. I'm going to be putting up more free-ish the whole time you're going to be on there. Also, you can get weekend learning goodies every Friday. So you got some stuff on the interwebs that's free to learn and go through that I found interesting. So check that out. Also, I offer 3 services on my website. Number 1, the mentorship program that I alluded to with the OCS thing. You got problems? Do you need someone to bounce ideas off of? Hit me up, man. We can talk. We can go through some of those problems. I can help you with learning some potential concepts, such as movement, many other things, training, physical therapy, whatever you want to go over, man. I'm here for you if you need that mentor. Other thing I offer is a movement consultation. Are you moving a little tight? Have you been through some medical stuff and you want to address movement a little bit more effectively, and maybe you've had some failures in that regard? Let's see what we can do online. I've got a couple of case studies that I'll link in the show notes where we had a phenomenal outcome doing all of this online. I offer those. Last thing, training. If you're an athlete, if you need to trim up a little bit, if you are post-rehab, those are some of my stronger suits. I could do some online training stuff for you. Go ahead and check out that. You can also check me out on Facebook. That's you guys right there. Facebook.com/ZCouples. You can check me out on the Instagram. Instagram is Zach, ZAC Couples. You can also check me out on Twitter. My handle is ZCouples. I put some profound-ish on there once in a while. Or I put out just some random stuff that's not profound and funny as hell. Depends on my mood. You can also check me on YouTube. That's you. Just search Zach Couples on YouTube. I think it's youtube.com/user/couplesperformance. I think. But otherwise, I hope you guys have a wonderful evening. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.